Good morning, all. It's a case of diffuse instant restenosis where I was helpless in debulking as well as optimizing the result. Can I have this next slide, please? The story is about a 47-year-old gentleman who had a PCI to LAD with drug-eluting stent in 2013 June. He presented about 16 months later with class 3 effort angina. His resting ECG was normal, so is his echocardiography. His treadmill was actually strongly positive at 4 mats, so we took him for an angiography. And as you can see, there is a significant left main disease. The circumflex is dominant and disease-free. There is a diffuse instant restenosis of the LAD stent, and we can actually see that the distal LAD is actually thinned out, and compared to the guides as a 7-front system, it's almost like 1.5. And the next step actually obviously to use to IVUS to identify the pattern of instant restenosis. We can't see anything much except for it's a long disease, but there is any calcium, there's any mechanical issues like stent fracture and any malapposition. So a lot of information we need actually, and we need to get it. I mean, we can get it only by using an imaging. It's a cranial view. We can see that the terminal LAD is diffusely diseased. There is a long segment instant restenosis of the proximal LAD. This was a 2.75 to 38 millimeter drug-eluting stent implanted last time. That was done without any IVUS. Now, let us spend some time in identifying this, discussing this IVUS image. We can see that there is a wall-hugging vessel. We can see the anterior intraventricular vein also coming. This is the stent which is starting on. And the stent is 2.75. The mid LAD is 2.75. So it's an angiographic sizing of stenting which was done in 2013, and distally it looks fine. But as we come proximally to the LAD, we can see that it's a 3.5 vessel, and this 2.75 stent is hanging in a 2.75. So the operator has not optimized the proximal stent with aggressive post-dilatation. So that was a problem which was leading to instant restenosis. Now we can clearly see that there is no stent fracture. There is a diffuse fibrous neointima. There is no tissue attenuation suggestive of thrombus. So these are vital points which will help us to treat this lesion, whether it's with debulking or it's some other strategy. Now, when we come to the second loop on the right, we can see that that's actually there's an arc of calcium. We can see from 7 o'clock to 2 o'clock. And, sorry, can you play the one on the right side? Okay, so there's an arc of calcium, and then this is a proximal LAD. Again, significant plaque burden of the proximal LAD. And as we come to the left main, you can see a significant lumen compromise of the left main. And we can also see the anterior intraventricular vein going up to the great cardiac vein. So with this, we planned debulking with rotablation. Two things we should remember when we do rotablate in instant restenosis. One, you rule out significant underexpansion, because otherwise you're going to cut through the struts. Second thing is that you should rule out stent fracture, because the fractured stent set will again going to hit the burr, and then you have catastrophic complications. So once we ruled out these two mechanical issues, then we thought of debulking not only the ISR tissue but also the distal tissue, so that to leave the outflow in a better fashion, so that our patency of the stent is long-lasting. So we did, this is a circumflex ostium, which was not having much plaque burden. Another important thing when we use a left main crossover stenting. Can you go to the next? Yeah. So this is a 1.5 mm burr. The one on the left, we are actually debulking the ISR tissue. The burr is going down to the deep LAD to take care of the distal LAD disease as well. So after that, we did multiple serial dilatations with IVUS guidance. We did a 2.75 mm balloon NC, then 3 mm balloon, then 3.5 cutting proximal LAD with the take care of the calcium. Then we did a stenting of the mid LAD with a 3 mm. This is a 3 into 32 bioluminescence. And then we overlapped with the proximal LAD to LM crossover stenting, jailing the circumflex wire. This is a 4 into 28 drug-eluting stents from the ostium of the left main to the proximal LAD, overlapping with the mid LAD stent. We followed up with a 4 and 4.5 mm post-dilatation, aggressive post-dilatation actually, because that area was not yielding properly. And then we followed up with the 3.5 in LM to LAD, and then 3 mm LM to circumflex final kissing inflection. Circumflex dimension, according to IVAS, was 3.2 mm, so we used a 3 mm balloon. Our idea was not to stern the circumflex because, as we saw, there was not much plaque burden in the circumflex. We just want to open the struts, and since we used 3 mm balloon. Now, this was angiography after the stenting. More importantly, we say that we deliberately avoided balloon inflation, balloon dilatation of the distal bud, because we'll end up in messy dissections and then outflow of occlusions, which eventually will damage all the good work we have done proximally. So the idea was actually to do a standalone rotablation of the distal bud and then optimize the stenting proximal and mid LAD coming back to the left main. Sorry, back. Can you play this movie? Post-stenting IVAS showed that there is significant lumen gain. That's what the beauty of this imaging guided ISR PCA is about. We saw that it's a 2.75 wall hugging lumen. Now we see that it's significantly expanded. Distally 2.75, coming back to 3, and then 3.5 to 4 to ostal LAD. I mean, we can see that there is a little bit of plaque-induced malapposition here at this point, but that's lumen area, surface area was significantly appealing. So this was after 3.5 and 4 balloon NC dilatations, and left main stent also looked nice. So coming back to the lumen cross-sectional area, left main we got about 13, proximal LAD we got about 10.3, and then middle LAD around 7.2. All are well acceptable values. And then we did up IVAS to the circumflex, which was again was a good value of 6.1. It doesn't demand any stenting. There is no significant plaque shift as well. This is the final angio.